All right, so I think we'll get going just to save a little bit of time here so we can have more time in the lab this afternoon. Again, my name is Ryder Gwinn. I'm a functional neurosurgeon here at Swedish, and the theme here is neuromodulation. This afternoon with stereotactic procedures, we've been focusing on movement disorders for the last couple talks. I'm going to go back to epilepsy again here. Really, as Dr. Willie was saying before, ablative surgery for epilepsy is the gold standard treatment for patients with medically refractory seizures. And there are a huge number of patients who can benefit from resective surgery, whether it's with a laser or whether it's with open surgery. But I'm going to talk about a neuromodulation treatment for epilepsy that's been just approved or really the second neuromodulation therapy after the VNS approved to treat seizures. And this was really born from the idea that was observed during intracranial monitoring for patients with epilepsy. Sometimes they do mapping. We do mapping and stimulate a grid and trying to shut down functional circuits to see where they are, and occasionally we start a series of after discharges when we do the stimulation. And folks at Hopkins found that you could actually stimulate again in that circumstance and oftentimes stop the after discharges. And the earlier you stimulated after the onset of the after discharges, the easier you were able to stop the after discharges with the second subsequent stimulation. So this was the genesis of the idea of trying to place an electrode over a seizure focus and stop the seizure by stimulating the seizure focus. And so the NeuroPace system, or responsive neurostimulator system, it's really the first attempt at closed loop stimulation, whereas the VNS and DBS is all open loop, where there's really no event internally that's triggering the stimulation. It's just a counter of time that's inducing the next stimulation. So here the idea is that the electrode is sensing all the time, looking for abnormal activity, and then processor determines based on the criteria that you give it that this matches a seizure, and then stimulate either there on the electrode or some other place via another electrode to try to abort the seizure. And you can see here the idea, it's very well known that oftentimes patients have a very particular electrical signature to the onset of their seizures. So if you're able to record from the onset site of a seizure, you can oftentimes see what Dr. Schiff called a chirp, which is a very unique spectral appearance, unique frequency, usually gamma frequency onset in the area where the seizures are starting from. So if we can find that gamma onset, and that is usually well before the clinical seizure ever starts, and we can stimulate right there, then we can potentially abort that seizure before it ever becomes a clinical event. And so this RNS responsive neurostimulator has really two parts to it, the sensing part and the stimulating part. For the sensing part, basically you want to be able to pick up abnormal activity from normal activity. So you create detectors using a series of tools called half-wave, line length, and area tools, and then it has a storage component so you can record electrocorticography and then analyze it offline later to help build detectors that will then automatically detect that seizure activity once you plug the detector back into the device. It also has this storage buffer that you can download to a laptop at any time you want. Patients will often download at home to their laptop and then attach their laptop to the internet, upload to a server where we can view it online. So right now we are routinely seeing seizures that are happening in patients at home within an hour after it happens if they download it, upload it to the server, and we can take a look at it online. The other half is the therapeutic component. Basically, we can use any of the contacts, including the can, as a anode or cathode, and we can use very flexible parameters in terms of frequency, amplitude, pulse width, and then we can construct a set of stimulation parameters that are also variable depending upon which treatment we're talking about. So we can have it detect and then give one type of therapy. If it doesn't stop the seizure and it redetects the activity, we can have it give a stronger or different type of therapy, and up to about 5 different types of therapy until it exhausts itself and said, okay, we're not going to do anything more until it drops out of a seizure, and then we'll redetect again. So the idea here is that here's an electrocardiogram of a patient that has a device implanted, but it's not turned on. And so you can see in the very beginning, you have this chirp, this very unique signal that indicates the onset of a seizure in this patient. And you can see here this blue line is where the detection has picked up the abnormal activity, but we haven't turned therapy on. So the seizure develops after that, then kind of runs its course and stops later on. The sort of what we're trying to accomplish here is this situation here where there is a detection that happens. It activates the stimulation. The stimulation, basically the amplifiers are turned off during stimulation so you don't see the stimulus here. And then it redetects. It finds that there's still some abnormal activity here, another stimulation right here, and it then redetects again, but really there's no more abnormal activity. So this is what we want to be doing with this device in all of our patients. So here's just an example of one of our bitemporal patients that have the device implanted with 2 depth electrodes, and the CAN, or the internal pulse generator, is then implanted in the skull. We basically do a craniectomy to take out the bone and replace the bone with a tray, and then place the IPG into the tray. And we'll take a look at that in the lab in a little bit. So this device has been under study for about 10 years. It was really, I think, 2003 when the very earliest study started. The last study was the pivotal investigation. That involved 32 centers with 191 patients that were implanted. And basically, these were the kind of worst case scenario patients for patients with seizures, complex partial seizures, having at least 2 to 3 per month for 3 subsequent months, and had to have only 1 or 2 foci. And really, they had to be localized prior to implantation. So here you can see the paradigm. Basically, they had to satisfy eligibility, take a seizure diary. They were implanted. We waited 4 weeks before they were randomized. Then they were randomized to either on or off. It was a beautiful study designed because patients really cannot sense when the stimulation is on or off, so it's a truly blinded study, and the evaluators were also blinded. So the surgeon myself was the only one that was unblinded in the study. The demographics, these again were the toughest of the toughest. They had 3 AEDs, medications at enrollment. They had a third of them had failed VNS. 60% had undergone intracranial monitoring. A third had already had epilepsy surgery previously that was unsuccessful. And then the onsets kind of match what we find in general resective epilepsy surgery, that about half of the patients were mesial temporal only, and then another about a quarter really were mesial and neocortical, and then probably about a third were neocortical non-temporal. Here you can see, here's the pie graph of it, half hippocampal, another quarter temporal and neocortical, or just lateral temporal, and then really only a quarter were outside of the temporal lobe completely. And here you can see basically during the blinded phase, there was a blinded phase as well as an open label phase, which went many years afterwards, but the blinded phase was 3 months long. You can see that after implant, all patients and most people in the field taking care of epilepsy patients know as soon as you operate on them with virtually anything, their seizures tend to decrease for a while. But then over the next 3 months, the sham group, the patients who had the device off, went back towards their baseline seizure frequency, whereas the treatment patients tended to get better over that 3-month period of time. And so the primary endpoint for the trial was looking at the average seizure reduction over that 3-month time period. But you can see that actually at the end of the 3 months, they were doing quite a bit better than sham compared to at the beginning of the 3 months. So if you clumped all those 3 months together, though, on average, the sham stimulation patients had a 17.3% reduction in their seizures during the blinded phase, whereas the on patients had a 38% reduction in their seizures. This is mean disabling seizures. At the end of the trial, we could see that there's no difference between sham and test stimulation in terms of any neuropsychological outcome factors. During the open label phase, there was also no deterioration in any measures, but you could see there was actually some increase in quality of life measurements with a sustained clinically significant improvements in overall quality of life, memory, this is self-reported memory scores, and attention and concentration. In terms of adverse events, there were a number of hemorrhages. There's about a 4.3% serious adverse event rate. There was extradural, subdural, intracranial hemorrhage, and then traumatic intracranial hemorrhage as well, really due to seizure activity that persisted after the device was implanted. There was also about a 6% infection rate, 15 out of 256 patients. 8 of those infections resulted in explantation of the device, but really no neurologic change as a result of any of the infections or hemorrhage. So in conclusion, from the primary study, the pivotal study, the primary outcome was met. There was a statistically significant greater decrease in seizure rate in the treatment group compared to sham. There was a low adverse event rate that was lower than expected given controls within neuromodulation, basically DBS rates that were looked at. And then it was approved by the FDA in November of 2013 for use. And we've done probably about 8 patients since the FDA has released it for use. But the long-term study patients have continued, and we just have published a paper in Neurology now looking at the long-term open-label outcome for these patients. And basically, you can see that these are combined patients from both the earlier feasibility study as well as the pivotal study that I talked about, combined them in a long-term treatment study and looked at them and how they're doing over time. And basically, again, the makeup of this was very similar to the pivotal study, and the outcome was also very similar to the end of the pivotal study in that if you look at this is the median percent seizure reduction that was at year 3, 4, 5, and 6. And you can see actually after the open label phase, the reduction in seizures increased to around 60% from 40%. So there was an improvement over time during the open label phase till about year 2 to 3 out. And then patients really stabilized. So patients in year 6 are doing about as well as they were in year 3, both from a median percent reduction rate and from a responder rate, which is basically the number of patients who had a 50% or greater reduction in the number of seizures. And then this is looking at the adverse event rate. And I would say the only remarkable thing here is that the site infection rate has gone up a little bit from 6% to 9.4%. And I assume this is probably due to the fact that the batteries are being replaced in many of these patients at about every 2-year rate. And that probably has resulted in a number of infections along the way as well. They do have another battery that should be coming out this year that has a longer life, but one of the downsides of this device so far is that it is a little bit shorter life than the typical DBS IPG in terms of we're getting about 2 to 3 years rather than 4 to 5 years for DBS. So future directions, I think that the NeuroPace really is a great new concept in how to treat epilepsy, and it really goes back to what others have been talking about in terms of thinking about functional disorders as network problems, and we're trying to here now access the networks and try to shape the excitability of the networks by placing electrodes in certain nodes. And we really don't know what the right nodes are. For the most part, right now, we're stimulating areas where we can record the seizures coming from. And that's kind of a simplistic way to think of it. I think in the future, we may use the sensing electrodes in one place, whereas we may place treatment electrodes at other nodes within the limbic circuit to try to stimulate. We know that there was a trial called the Sante trial with deep brain stimulation of the internucleus of the thalamus by Medtronic, where there was just closed loop stimulation of the thalamus that did show benefit. And so combining both responsive stimulation with kind of more of a closed loop approach, I think has potential to have a better impact on treatment than just closed loop stimulation alone. And then again, kind of like the VNS, we're very, very early in knowing what kind of parameters are going to be useful to stimulate patients and reduce their seizures. And I would say that, just from the placement of the 8 or so since the trial, we again have patients that are all over the place, 1 or 2 that are basically seizure-free, and another 1 or 2 that have not much of an improvement so far. So I think that's all I got. Any questions about responsive neurostimulation? Yeah.
So when you got 2 electrodes, use the same system for both?
Yeah, so the pulse generator you can attach 2 electrodes to the IPG. Each electrode can either be a strip or a depth electrode, and so you can treat 2 separate targets with one electrode each, or treat 1 target with 2 electrodes, and they can be deep or surface.
Okay.
Does that answer your question?
Yeah, and they work simultaneously or just separate from each other? Like, for example, if it's an activity in one side, it will just direct its activity to stimulation to that side?
It's totally up to you. You can design it so that the detector on one electrode is then treated on that same electrode. You can detect on one electrode and treat on the other. Totally up to you how you put it together. Yeah.
Why does the IPG have to be implanted within the cranium? Why can't it be implanted elsewhere?
Yeah, that's a really good question, and I don't know the actual answer to that. I would say that what I see as the most likely answer is that the signals that are being collected off the depth electrode and the surface electrodes are unamplified and subject to noise as those wires get to the analog to digital converter. And so the longer those wires go, the more noise can be introduced and less fidelity of the signal. So particularly as it goes through the neck, if there's movement of those wires, you can introduce noise. I suspect that's why they designed it that way, but I don't know the answer to that. I would say that certainly a subclavicular placement would allow for a bigger battery, would allow for some easier access, although I would have to say that replacing the batteries there is really not such a big deal. It's pretty easy for the patient to go through. We don't generally shave their hair when we replace the batteries, but I think once there's a rechargeable or once there's a longer life battery, it's going to be a lot better for sure.
Yeah, I think that is why they designed it that way. But the other thing is, when technology was all being developed, it was about the time that DBS itself was really becoming widespread. And at the time, there were a lot of hardware complications and breakage of the electrodes because the methods were still being worked out. So I think people thought it would be a better idea to get away from having the chest and the neck movement. And finally, it was sort of thought up by a neurologist who didn't really understand all the surgical complications of these things. And while putting in the head can be a very safe thing, we obviously have long-term concerns about skin breakdown of having to go through multiple, redo incisions on the head. So I think the rechargeable is going to make a big difference.
Yeah.
And I also want to stress that this really is this is not a competitive treatment with other ways of doing epilepsy surgery, such as the laser ablation. It really increases our toolbox of all the things that we can do. For instance, this might be the perfect therapy for obviously the bitemporal epilepsy patient, but also maybe the dominant temporal lobe epilepsy patient that's MRI normal and normal neuropsychological function. That's a patient that's at very high risk from any type of resective approach. And so this is this sort of thing that you might use for that patient up front without thinking about an ablation or a resection on that patient.
Yeah, absolutely. I mean, I would say for all the patients that we enrolled in the trial, they were patients that we did not think would be safe to undergo resective surgery, and so either foci in language or motor areas. I don't think we did, but there were other centers that implanted dominant temporal lobe patients who did not want to undergo the risk of having language or memory decline. Certainly for a non-dominant temporal lobe, we would have recommended surgery rather than any kind of neuromodulation procedure. But as he was saying, it just increases our toolbox. And as he was saying before, we want seizure freedom, but we also don't want to cause any long-term cognitive effects in patients. And this allows, I would say, this is on the safest side compared to the laser ablation or certainly open resection. But we need to bump up the efficacy side to really make it a no-brainer to decide to do this over resection.
And there's one other application is that sometimes we're not sure if it's bilateral temporal lobe epilepsy, and despite our best efforts, we can be fooled. And so you can actually do this, and it's like a long-term intracranial monitoring experiment where 6 months down the road, you might have the data you need to know really the entire problem is on one side, and now maybe you do a resection or ablation on that side. So it can potentially be used that way because sometimes, despite our best efforts, the tests that we do are not perfect, including intracranial monitoring. And so having that long-term aspect of it, or somebody who fails intracranial monitoring because you put them in electrodes and they don't seize for 6-8 weeks, and then you have to take things out. So it can be useful for those types of patients as well.
There's actually a couple articles out now about that in terms of using the RNS, particularly for bitemporal patients. This is a sort of a big problem in epilepsy surgery where, either there's bilateral hippocampal sclerosis, but you don't know if it's bilateral seizures, or unilateral sclerosis can still have seizures coming from both sides. And so we really are starting to think about using this as a long-term monitoring device as well as a therapeutic device kind of built into it. Because we know that when we suspect bitemporal epilepsy, we often just want 3 or 4 seizures, or we can only get 3 or 4 seizures while they're in the epilepsy monitoring unit with temporary electrodes. But this paper that's come out has shown that patients can have 7 seizures from one side and then have a seizure from the other side. And they're bitemporal, but we would have never known if we just collected 3 seizures and then said, okay, we're going to take out the electrodes and then make a decision about resection. So we get a much more informed decision about resective surgery if we can have this really long-term chronic monitoring situation as well. So,
So in the pivotal trial, the receiver was off for that, or was there was it responsive stimulation for the pivotal trial?
It was for the treatment group. For the sham group, the detector was turned on, so you could configure your detection, and then we would pretend to test stimulate when they were in the office, but the device was never turned on for therapy for those 3 months.
So is there any kind of different algorithms being used after that trial, what got the FDA approval so far as how to use the closed loop stimulation, use the receiver?
Well, it's all one device, right? So the receiver and the stimulator are all one. But I would say that there is a set of sort of standard parameters that NeuroPace has suggested to most centers to start with, but there is no consensus on that one set of parameters is clearly twice as good as another at arresting the seizures.
And how do patients like the system? It's like you get the bowstringing with DBS. We talk about miniaturization. We think about, again, patients in their 50s who would elect to have this done when they're still working and gainfully employed and, maybe still some vanity and all that.
Yeah.
How do the epilepsy is obviously a different kind of patient group overall, but
Yeah.
how's that experience?
I think from a cosmetic standpoint, it's actually really good. I think it's better than DBS because it's totally, underneath the skin in the head. There's no wires through the neck. There's no IPG underneath the clavicle. But I think you basically will answer that question by answering whether they're seizure free or not, or whether or not they've had a big impact in their seizures. We've had a couple patients that have been pretty much seizure free for years now, and if you ask them how it is, it's like fantastic. It's really made a big difference in their lives. And I think for the most part, patients, the real test is, do they come back to have their battery replaced? And if they don't think it's doing anything for them, then they're probably not going to want to undergo surgery to have the battery replaced. And we have not yet, to my knowledge, had any patients just not come back. So, all right, so let's go ahead and change. There are bathrooms over here. The scrubs are in the bathrooms. We'll change and then go into the lab. And there's not going to be any set groups where you actually have a number on your badge, but that's for the stations that you're going to go to tomorrow for the cranial approach procedures. Today we have 5 different stations, and you can go to whatever station you want to see first, and then we're going to take you through each of these applications, and then